So we're talking here about what's going to happen with respect to, we had a great last session talking about partnering versus purchasing. And one of the key questions that came up was legacy systems, technology stack. This is a great natural transition to talk about what should our current health IT architecture be as we go forward. So before getting into the Q&A, Fred, do you want to introduce yourself? We'll do that with John, and then we'll jump into the questions.
Sure. Fred Holston. I am a director of healthcare at Sirius Healthcare, formerly the CTO of Intermountain Healthcare, and happy to be here. Thank you.
Awesome. John.
Hi, John Henderson, CIO for Chalk Children's here in Orange County, California.
Excellent. Welcome, both of you. So this idea of exponential increases in virtual care, we've seen an increase far more than we thought we would pre-pandemic. So that's all obvious. What do you guys think with respect to pure infrastructure and architecture is concerned from a health IT perspective? Should we start concentrating on if we are to continue meeting this same demand? Or is the demand out of proportion right now and just going to go back and we shouldn't worry about architecture at all? Hey, John, I'd love for you to jump in and talk to us about how much should we worry about our health IT architecture now based on what we've learned in the last 15 months or so.
Right. We can't think we already have everything in place. We have to pay really close attention to it. I think the virtual care and what's happened over the last 15 months has really put a spotlight on a number of things in healthcare technology delivery. So I think the architecture elements are really critical, not only from a capacity perspective, but really looking at this as a connected world of virtual care and all of the different elements, whether it's the video, whether it's connected devices, all of those things are going to play a critical role in how virtual care evolves. The traditional mode today obviously is through video conferencing. But as you start to add more and more devices and wearables into the mix as part of virtual care, having the appropriate infrastructure to support that and the collection of that data and really the ability to aggregate it and use it in meaningful ways, that's really going to be dependent upon your IT infrastructure and architecture.
Mm-hmm. And John, at your institution, talk about some of the big initiatives. Is 5G something you guys care about, don't care about? Universal broadband. What else would you jump in and talk to us so that our innovation community members that are listening to say, oh yeah, that should be something I should care about as well because my customers care about it. So what are the top initiatives that you care about most at the moment?
Right. So 5G is important to us. We are paying attention to it. From our community and who we're trying to serve, we think 5G is going to play a really critical role, not only for Orange County. We're trying to serve really all pediatric populations in the region and even beyond. So when you think about what 5G can bring to rural communities or to communities that are socioeconomically are not in a position to have the traditional infrastructure within their communities, we see that as a real opportunity to reach out and connect with those with those patients and patient populations. So we're paying attention to it. We believe that it's going to take a while to really reach those areas because it's still in its early stage, and it typically takes anywhere from the launch of a solution capable like 5G at least 5 years for that to have broad access. So we're paying attention to it, and as we're thinking about virtual care, we're looking at all sorts of ways, whether it's the ability to provide devices with broadband access, with those cellular access, with those devices to help create more access, partnerships with schools. We're looking at all those types of things to kind of broaden the population that we reach.
Got it. Fred, from your perspective, and you can talk to us about as you were coming out of Intermountain and what were the key technologies you were looking at as CTO. And now, from your vantage point as a innovator on the outside, what are you hearing hospitals talking about most that you would bring to the audience and say, hey, you got to pay attention to these initiatives because that's what hospitals care about?
Yeah, I mean, coming out of Intermountain, I think we were talking about what traditional virtual care, telecare, we were certainly doing EICU and those kinds of things coming out. Here's what I see going on right now. It's really, I'm terming virtual care a little different. It's really touchless care. It's really this idea of how many things can I do on behalf of clinicians, on behalf of patients, nurses, whomever it happens to be, and be touchless about it, whether that's vitals collection, whether that's monitoring for the 1,000 things you can do with movement and video, or whether that's very traditional specialty, televisits or whatever it happens to be. What can I do touchless? And so if you see and think about what we're doing on our side in looking at patient room, and patient room for us is a very nebulous thing in the sense that it's not just traditional patient room, it's home, it's in the parking lot, it's wherever that patient's getting treated. And you think about that and you think about what do you want to do next? I'm trying to figure out how to be touchless. And in that, there are a number of solutions which are going to overwhelm clinicians. So we have to figure out how not to do that. And then what infrastructure can we make that's common amongst all of those so that we can retrofit areas, rooms, black boxes that go home, whatever that happens to be, one time or as few times as possible, and then leverage and do and add as the technologies come along, as the need comes along, in this touchless virtual care.
Got it. Yeah, that makes a lot of sense. And John, would you concur with that terminology of touchless, or would you kind of like shift that definition a bit as well?
I'm going to steal Fred's term because I love it. Touchless care. I love it. I absolutely agree. It's always different in the pediatric setting because when we have chronic cases with patients that from the wearables device perspective, those are really difficult to really attach to our patient population. If it's diabetes, glucose monitors, you're starting to see more things that we can provide externally while they're at home and be able to capture that information. But where it's really lagging behind so far is seamless and automated continuous flow from those devices back into our EMR, which can then be translated and used in a meaningful manner for the clinicians to understand, are they on regimen? Are the levels dropping? Are they good? Are they rising? Those types of things are still in I'll call it the early evolution stages in the pediatric population. So I think the architecture to support that is really what we're interested in, but also the devices, the innovation that's coming from startups that can help us really reach those populations in a much more meaningful way to really track and measure their progress when they're not in a physical space that where we're providing care.
Yeah, that's perfect. So Jeet, welcome. We'll let you take a couple of seconds to introduce yourself, and then I'll present the same question. I'll repeat it so that you can provide it as well. So just a quick intro, and then I'll ask you the question.
Sure. Hi, good afternoon, everyone. I apologize, I'm a little bit late. There were some issues again. It's never a dull moment, with some cookies, it was fine during the rehearsal, and all of a sudden they changed the group policy on my PC. So again, I think they did it for the right reason, but on a wrong day. So I'm glad we all joined. Thank you, Shahid and John and Fred. Shahid, I could not hear the first part of the question, so if you can repeat.
I'll repeat that. So we're talking about what are your major initiatives at your facility with respect to HIT architecture and infrastructure. So we were talking about things like, is 5G important, or is it mostly hype? Is IoT, the idea of getting devices out there, is that hype or real? How much do you need or other initiatives in order to move into more exponential hybrid and new kinds of care that you're working on? So what are your focus areas for their HIT architecture?
Sure. So it's a very loaded question, and I will dissect it slowly from the skin all the way to the organs. So first of all, the COVID last 12 or 14 months has taught me personally and taught us in the department that we need to be agile. And there were certain things which we did we could not have imagined. So whatever architecture we had, or we are going to have, or we have to be agile. So that is number one, and flexible. We are hybrid, and for a foreseeable future, we would continue to be hybrid. That is another thing which COVID validated for us in a mid-size community health system. In terms of the 5G, I'm a big proponent of wireless 6. You must have heard in my previous conversations. I would not say 5G is a waste of time, and I have a conflict. I sit on the board for Verizon for healthcare on 5G. Yes, there are a lot of advantages for especially some innovation work which is going on in the virtual or AR space. But overall, from the architectures, I would recommend, or I would um, muscle my arm with Cisco or other networks that we ought to be working on wireless. It's a myth that it's not very safe or secured, and I think if it is configured properly, wireless can take up to gig. Again, I'm sure most of you are more knowledgeable in technical skills than I am, but yes, wireless, in my opinion, can take up to a gig, and that's more than sufficient for the current healthcare needs. Even if you are exchanging real-time videos, whether it is virtual care or provider to provider consultations, I think it should be more than sufficient. So again, I'm a big proponent of wireless, especially the wireless 6. So if I have to reconfigure my architecture for next 48 months, I think anything beyond 2-3 years, we do not know. The things are changing so fast. I would be spending more money on the wireless technologies more than 5G. But nevertheless, there are some very good use cases for 5G. I have no doubts. I have seen them. I have used them. But from the health system perspective, cost perspective, I would be favoring wireless 6. Um, it's like depression. Nobody talks about it. Everybody talks about 5G, and everybody has depression. So something in that. It's an open architecture. It's open just because it does not have too many commercials.
Yeah.
It's not propaganda. There's no propaganda. But I'm sure John or Fred or others who are on this discussion would somewhat agree with me. Wireless 6 is the present and possibly the future, actually.
Yeah, and Fred and John, if one of you are dying to answer that, that's great. Otherwise, I'll ask another part of the question, which is, where should you be looking for help in these kinds of HIT architecture type of things? We see a lot of solution providers coming in and talking about software as a service and this new piece of software, that new solution, but very few seem to be actually helping with infrastructure to keep going. So
No,
it looks like you have something to share there, and then we'll bring in Fred and John.
yeah, Shahid, I think there is already a standard, IEEE, actually. I do not currently recall the version, but IEEE has standards for Wi-Fi 6. And if they are configured properly, I mean, again, I want to emphasize the word configuration is the key. Otherwise, you will end up having the same cellular issues as well, spotty and not getting what you need. So I'm sorry, John and Fred.
No, go ahead, Fred. We'll let you jump in talking since you after you left Intermountain, you've joined a firm that actually helps with architecture. So, what are the kinds of things that hospitals and health systems should look outside for with respect to HIT architecture assistance? And then, John, I'd love for you to talk about that same thing as well.
Yeah, I mean, obviously, in my conversation about touchless, right? You can't do touchless without some form of wireless, and I think there's several. You can certainly, as you go home, and we talk about the black box going home, all that, certainly 5G and others become interesting. Yeah. I certainly agree with where Wi-Fi is and where it's going, certainly for in-hospital. It's going to do, yeoman service of most of what we need to get done. And I think that continues to be true. I think there's some other standards, whether you call it Zigbee or the meshes or any of those kinds of things, I think which will play in the IoT space. Having said all that, being wireless, you really have to begin to back into what you want to do. And when I say you look at all these, we're starting to look at all these solutions for touchless, they all come back to a relatively common, I won't say back-end infrastructure, I'll say middle infrastructure. Right? They're going to be a little different on the front end. Some are cameras, some are mics, some are IoTs, but in the middle, they're kind of all the same. And in the back end, they may have different software. They may require NVIDIA cards. They may require something else. But this part that you have to reconfigure your hospital, or this part that has to be put in the black box and taken out to the parking lot if you have a COVID situation or that might go home, that's going to be pretty similar to all of them, whether that's just a pure networking or the fact that you can put in one set of cameras for everybody or one mic for everybody, or one IoT hubbing mentality, which, by the way, gives you new security opportunities if you consider it, in that method as a room, and again, room being very broad, but as a room having its own IoT kind of hub per room, then you can secure things very differently than you do at the enterprise. There's a whole nother set of things, and that's an infrastructure that I think, again, you can do once or a few times, and then pick your solution over time as money allows, time allows, interest allows, the technology matures. And so, anyway, my opinion.
Yep. So, John, how would you then tack on to that to say, are you primarily trying to discover this on your own, or are you going to outsiders? Like, very rarely do hospitals and health systems build all the software that they need. Very rarely do you build any hardware, almost. So where do you go look for help? Who are you out there seeking advice from about these? Is it mostly internal, or are you going out to other vendors to help you there?
Right. So having partners, going external is important, and that's a big part of our portfolio. We have a great team here, a great CTO and Adam Gold, but you really need partners. So the kind of approach we take is, I think, you think about wireless and networking, core wired network versus wireless. You want to make sure you really understand and have a partnership with your vendor. We're a Cisco shop, so having that partnership and really working with them is important. Fred is with Sirius, great organization. They provide great advisory services and expertise. E+ is another partner that we've leveraged, Instance 360. Those partnerships are really important because they really help you understand what's happening across industries in healthcare, but also even beyond that, because Fred kind of mentioned this. There's certain parts of the infrastructure, it's going to be common no matter what. And so you have to consume those components. But when you get into those different use cases, whether it's you're tracking, you need to have access to streaming data. How do what's really needed for that? If you think about AR and VR, that's something that we're very interested in. We have a couple of initiatives right now with AR and VR in the clinical education, patient experience setting, but there's so many opportunities for that in the healthcare setting. How do you design your architecture and make sure it's ready to handle all of those capabilities? And you have to leverage partners to really help you along with the expertise that you have internally.
Yeah. So there's a quick question that came up from Nick here. I will go ahead and pick it up and weave it in here. So he was asking about the fact that there are many touch points that patients are going through for different physicians. Patients can visit different physicians from many different facilities through video. Data exchange between healthcare providers has found many roadblocks. Where do you see patient-owned data progressing over the next 5 years? And does that really impact architecture? Or is that more on the software side and interoperability is kind of separate from this HIT architecture discussion? Jeet, you can jump into that first, and then we'll let Fred and John answer as well.
Yeah, I think it is multifactorial. I would not pinpoint on either software. I mean, there are obviously interoperability standards and also the processes, and it's becoming more portable now than what it used to be 2-3 years ago. And with this year, several regulations are making it even easier. So the meaningful use 3 now what is called as PI, or promoting interoperability, the certified EHRs have become more agile, and you can exchange information through CCDAs or whatever the newer standards are. So yes, to answer your question, it is getting better. Are we there yet? Not at the moment. But there are, again, several other initiatives like Open Notes or pushing information through patient portals, or patients having the ownership of their own records. So I think these are all coming together. Probably in a year's time or within 24 months, we should have a better accessibility of the patient records from the patients and between the providers to providers too. So I think the work has begun. Maybe in 2019, last year was a little bit some challenges we had to postpone, but I think this year we have again taken up that slack and moving in the right direction. So
yeah, and so Fred and John, I'll let you guys jump in just to refresh everybody's memory. The patient access requirements from what was supposed to be January 1st has been pushed to July 1st. Data blocking and the Cures Act rules are already in place as of April 1. And the payer-to-payer exchange rules are coming in January of 2022 if Mr. Pandemic doesn't push those further out as well. So there is a question with respect to whether or not patient-owned data is important or patient-accessible data. I don't believe that in the United States there's going to be any real conversation about patient truly owning their data in the sense of GDPR or others, where people can say, look, I want to have a right to forget. I want to be able to own my data, so everybody who ever touches it, I will know about. I don't think that's coming. There are no current regulations in place. Congress, as notionally broken as it is not about to come into one. So so from Nick, your particular question, if you're wondering about patient-owned data, forget about it, right? For the next 5 years, patient-owned data is not going to be on anybody's priority list. But patient-accessible data is on everybody's priority list, including what Jeet just mentioned. So with that, John, specifically on the pediatric side, this idea of patients, especially moms and dads, et cetera, having access to their kids' data is paramount, right? So what are you seeing with respect to the benefits or pickup with respect to the data unblocking rules from April, or maybe the patient access rules that are coming into effect in July? Is that real? You're going to see some benefits there, or still a ways to go before patient accessibility of data is paramount?
Well, I think we'll see some benefits, and so I think it's necessary to have those rules and regulations. But I'll say I'm a bit cynical when it comes to interoperability as a whole, because there's a fundamental disconnect with the ability to share information, which we can do today between EMRs. You can even do it between an Epic and a Cerner. You have CareQuality, you have Commonwealth that allows that exchange. That can benefit the provider organization, I believe, more than the actual patient family. So when you think about patient access, real interoperability from a patient access perspective, particularly when you get into pediatrics, you may have multiple providers. You may switch providers, and they may have different EMRs. You may have a great access to that EMR's patient portal, but none of that is continuous information. I feel as a parent, and as I move into adolescence and I have access to all of my information as a 15-year-old, I'm still having to navigate multiple portals to see my record. Now, while I have access, that's not making it easy for me to see the whole continuity and continuum of care received over multiple years. So I think that's still where I'm cynical. There's no focus on that. I see nothing in whether it's legislation, or there's no real desire, I believe, within the vendor space to really solve that. I think that's really important for the patient family to have that access to that information in a way where they're not having to hunt and peck for it.
Right. Makes sense. Fred, do you have some thoughts one way or the other with respect to, do you share the cynicism, or do you feel like some of these rules may move us into a direction faster where at least patient access is going to be easier? Like I don't buy the argument about patient-owned data, but patient-accessible data. How are you feeling? Similar to more John, or more optimistic?
Oh no, I'm with John on this. I'm very cynical. Because this is not a technical problem, right? The technology to do exchanges in any of this has been around for 15 years, if not more, but it's been around for a long time. It's been our desire to really make it happen. To John's point, the moving between providers, doable, today. I really see this as in this bidirectional patient, not owned, but accessible kind of data thing. In going to providers, it's not a technical problem, it's a trust problem, right? My physician doesn't trust the data that's coming from me. Trust the data that's coming from a provider, but not from me. And so what does that mean? You know, what does any data I might provide mean to my, you know, somebody that's treating me? How will they consume it? It can be too much data. You know, how do we quickly move that into something they can consume quickly? They don't have time to sit and read and study and look at patterns. We have to work on that as data comes into the organization. Then you have the other side is data coming back. And, you know, John talked about it, like, I don't get this continuous stream of data. The question is, who's going to do that? You know, you're going to get a few startups who have tried. Google Health, Microsoft Health have all tried to be those central hubs, but I don't know, other than some niche companies out there, if we collectively have really tried to figure out, how do you hub this for people so that you can have, look, it doesn't have to be one app that you have, but they all go to the same place, that app gets the same information as app 2 would get, as 3. And so you can play with how the look and feel is. And I like that, the way that's presented. Oh, they do some site analytics, but they're getting their data from the same place. And all of those are getting their data from sources that I have all said are mine. Look, I go to 3 different hospitals. I see 5 different people for 5 different things. How does all that data find its place to a streaming, I call it a hub, right? This intermediate thing that then can feed whatever it is I want to feed and see it and use it the way I want to see it and use it. And I don't think that's emerged. It's not a technical problem. Again, that is not a technology problem. We do it in every other aspect of things that we do, whether that's prescriptions or banking or anything else. We do that today, not technical problem, but who's going to rise to the occasion? And then what is a business model around that? Patients don't want to pay to get their data out from all these sources and put into my world. So who's going to pay the bill for somebody to rise to be that intermediate who's going to say, okay, you tell me where your data is and I'll work with them to get it all and pull it through, which again will all be standards based. What's the business model around that? And I think those are challenges, things that have to be kind of resolved, before we get really good data moving in either direction. It's just, my view of the world. I stay cynical.
Yeah, no, and I think that cynicism, we could call it realism, right? Because what I see our problem really being is we don't have a unified non-variable demand that says, like, for example, Wi-Fi 6, there's a standard that says, let's go to Wi-Fi 6. Here's what the 802.11 standard means. Everybody start installing it. Things are interoperable. We move on. Now, if you had a unified demand capability, say, okay, I'm looking for this hub and it should bring in these kinds of information, I believe that's probably where more of our problem is. So if anybody in the community wants to put together maybe a couple of open source projects or capabilities to bring and unify the requirement side of this, right? A Sirius could certainly do this, where it could work with multiple hospitals and say, hey, how about we define what that hub would look like? And then once we have the same almost non-variable requirements from multiple hospitals, or even let's say multiple pediatric hospitals, forget like general hospitals, but if we said we're going to go to 10 pediatric hospitals and all 10 of them have this unified demand, then I believe we might be able to get some of those, because if it's not a technology problem, then it's got to be a demand or requirements, quote, definition problem. Fred, do you buy that argument, or too loosey-goosey still?
Well, I mean, one, I don't know that all patients are demanding it, right? I mean, there's kind of a mixed bag here. Number one, you don't have necessarily everybody in the country going to a lot of different places, right? I mean, if they're largely in chalk, with their kids, then for them, the chalk access method probably will largely satisfy most of their needs. So the question is, and again, as you see brand, you see the millennials and others, frankly, even me, who aren't as loyal to a health system as maybe they used to be. Of course, I'm a traveler, as some of you know, with a family full time. And so we see different health systems that's part of it, right? And I don't know if we'll ever get patients just clamoring as hard as we think we probably need to help solve it for them. I think we'll always say, because again, healthcare has been pretty easy to say, yeah, tough. That's just the way it is. And unless some regulatory thing comes down and just mandates this big, single streaming kind of thing, which we'll see about that. They have to have access, but we solve access in a lot of different ways.
Sure.
I'd like to kind of add to what Fred is saying. I think I'm going to jump off a cliff on this one because there's probably many different feelings that folks have about what I'm getting ready to say. I believe that there isn't that universal demand from patients to say, hey, I need you guys in healthcare to do this better. They want better access. They're really clear about that. But I think in order to get to something like this, if we look back at what's happened since the pandemic, I think this really requires a true federal government private partnership to create that hub that Fred talked about. I think absent of doing something like that, where the standards are set, that hub is created because it's good for public health policy. It's good for the country to have better access, for patients to have access to this information in a very simple and easy way that can be trusted. I think absent of something like that, you can't really make the traction, because otherwise it'll be a state by state or geography type of scenario where you're trying to create it. And then what you get is what we saw with the pandemic. We couldn't see what was happening across this country to better help us manage this pandemic and what was really happening across the country, because there's so many different ways in which data is captured or not captured. And there's so many different forms of how states, local governments, and federal governments were actually trying to track all this. It's not a clear standard across. So I think things like that, it makes it very, very, very difficult to achieve success.
I mean, it's a little bit of the HIE model, right? We've been trying, was a little more of the provider model, but it's that same kind of thing, but it kind of got done by states and regions and those pieces, and marginally successful, but not really doing what I think we all set out to do, which is, hey, me from California can reach out to Maine and grab what I need to grab. Those don't necessarily, I'm not saying you can't, but it's not where that needs to be. And again, that was provider, but that same mentality, if we're not careful, we're going to wind up with HIEs for patients, and we're still not going to reach across the various divides that are, where data happens to live.
Sure. And Ajit, I'd like to ask you one question that Richard just posed, getting back to our architecture pieces, because we talked about data, and it doesn't look like, unless we fix the demand side, it doesn't look like any infrastructure is actually going to help on with the data side. But the question Richard asks is, with most virtual care occurring at the patient's home, should the greater need be to cross the digital divide with the lack of any broadband, like let alone 5G, to our rural populations? And Jeet, I asked you primarily first because while you're not in a rural environment, you are in an environment where not everybody has equal access to hardware, technology, internet, et cetera. So if you want to give like a 30-second background on your facility and the kinds of patients you serve, and then talk about how are you helping your patients with the tech that they need from the infrastructure you're thinking about?
Yeah, so again, this is a social determinant of health, broadband access. And we have been advocating for our patients in various forums, whether it is at the local level or the state level in New York, either getting the price down for their technology services, or even handing them out the smartphones so that at least they can access either audio or video or whatever form they want to reach out to us. It is challenging the way we do have various hotspots in the county where there is a digital divide or digital desert, desert they call it. And yes, we live in urban areas, we serve urban population, but still there are some challenges accessing broadband in our communities. So I think it's a multi-pronged approach, both from the private side and also from the governmental side. If there is a legislation to bring down at least half or at least 1/3 the cost of wireless or the cellular access to the providers, consumers or the community members. And for certain group of members, we do provide cell phones on a limited basis.
That's great. And John and Fred, before I let you guys answer that, if there's anybody, we've got about 5 minutes left in this session. If anybody on the audience side, we've had a lot of active chat here with questions asked. I'm going to keep reading those. So if there's anyone who wants to come on, just drop in the chat that you'd like to come on and hit your live button in the top left corner. Your camera and mic will let you on. If not, please do keep asking. And so we have another note. So it looks like, let me just make sure I can read this all the way. Deborah Mansfield had written something for you, John. There's a devices model called ship-MD. There's a URL that she gave out. Definitely let's take a look at that. Now, John and Fred, do either one of you want to add, how do you choose the right infrastructure for your hospitals and health systems to make the access of the technology more equitable to all? Or is that something that the government should take care of, kind of like what Jeet was mentioning? Fred, I'll let you go first.
Yeah, hard question, right? I mean, I certainly think we need to deal with whatever inequities exist in day-to-day life around the digital divide, which will solve our particular problem. I don't know that we as health systems or providers or providing care, and we talked about the touchless and all that, I don't know that we can do a lot of tuning to that. I think we have to say, here it is, and that's a piece that I don't know that we can go solve. I think it is something that needs to be solved. I think it is a critical element to be solved. I think there are lots of people that are thinking, working about it, because it's a problem. It's a problem for education. It's a problem for, many other things, right? Not just health.
Healthcare, correct.
So I don't know that it's something we can get too involved in. I certainly think as we look at what we offer our patients in that digital space, we have to offer options that aren't always heavy. In other words, it can't always be heavy video. This is the only way you can do this, right? So tele in many cases can be done by chat for certain situations. Again, they're limited, but there are things that we have to offer those where they're probably more widely available than maybe some of your patients, where you're not going to get be able to have strong doing what we're doing right now, right? And I'm sitting on 100 meg, and that's not going to be always, the possibility. So I think we have to keep those things in mind and have options to them, but I don't know that we can go solve the bigger problem.
No, and I love that, especially as a fellow technician, it's perfectly reasonable for us to say this is outside of our scope. Doesn't mean it's not important. It's just outside of our scope. If somebody says they need cars to get to the hospital, we're not going to go buy cars for people, right? It's okay for us to say that there are techniques that we can use to help you get the access that you need, but I'm not buying you your car, I'm not buying you your home, etc. And I think that's really, I like that, the more adult conversation that says, hey, that's a problem that other people need to solve. Very important to solve, though. But one part that did catch my attention, John, is that we've been hearing a lot about telehealth, forgetting the fact that the original part of tele was telephone from the 60s and 70s is when that really kicked in. What we're hearing is that if reimbursements can be done for phone-based visits, you'd get a lot more equity. Do you agree with that? And how do you see the pure tele voice mostly helping or hurting with your kind of patients at the pediatric institutes?
Right. It's an interesting concept. I think anytime you can gain access, whether it's with the phone call or with video, it's going to be better than no access. Mm-hmm. So I'll state that. But I do think that I think we're settling as a country, and if we're going to rely solely on, or I shouldn't say solely, if we're going to start to have telephone as a primary vehicle for providing care, to me that's settling. I think we can do a lot better. I think part of what Fred was referring to and G did with the social determinants of health, it's a complex problem, right? Multi-layer. I do believe the federal government has a role to play in balancing out the inequities. I also think health providers have to plug into that, because if you think about it, and obviously I'm speaking from a pediatric perspective, there's so many different layers that you have to deal with. How many jobs does the mom have to support that family that needs care? And are they going to take off to bring their child in for care? Or are they going to go to work? If they have to make a decision between feeding the family or keeping the lights on, they're going to feed the family and keep the lights on. as opposed to coming to preventative care. So I think when you look at all those different elements, you have to look at it holistically and really understand that if we're going to really solve this, improve access, you have to really deal with social determinants, but you also are going to need federal assistance to really help level the playing field across the country where those inequities exist. Not solely, still need public, you still need private partnership with that, but I think they have to play a bigger role.
Yeah, makes sense. So we're down to our last 30 seconds or so. Does anybody have any quick closing remarks? Otherwise, we'll then head to our next cybersecurity session. So thank you, Fred, John, Jeet, for talking about the HIT architecture and infrastructure, and especially for Fred, he's available for you guys to ask questions. So if anybody has any questions about how to architect their environments going forward, definitely reach out to Fred, but Jeet and John are also available. With that, I don't see any other. Oh, there was one other one.
Wi-Fi 6, Shahid. Wi-Fi 6.
You've already said Wi-Fi 6 is the way to go. So 802.11 next is our model to pick as opposed to just 5G. So let's look at both, I think was the.
Yes.
So we've got the questions captured. We're going to put those in the on-demand sessions. Reach out, and then we'll see you at our next session starting on cybersecurity in about 30 seconds. See you there, guys. Bye.
Thanks.
Thank you, John. Thank you, Fred. Thank you, Shahid.
Thanks, Fred.